Good morning. My name is Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association. This presentation is intended to inform patients and caregivers participating in the Heart Failure Society Association's Patient Day, which is taking place on December 5th, 2020. As with everything 2020, things are a little bit different. So I hope that you're enjoying the participation in this event. And I hope in the next few minutes, I can tell you a little bit about the HCMA, what we do, why we do it, and how we can serve you. So without further ado, I will get on with this chat. So the history of the organization, as I said, I am the founder of the organization. In February, our organization is 25 years old. We were founded in 1996, and that came from a personal story, as you can imagine. My family has been affected by HCM for multiple generations, and in 1995, my sister passed away suddenly and unexpectedly from cardiac arrest due to mismanaged hypertrophic cardiomyopathy. That led me on an endeavor to learn more about HCM as a patient, and then to start to get patients organized and educated and build centers, which I'm all going to talk about in the next few minutes. So 25 years in, we have served many thousands of families with HCM, somewhere in the excess of 15 to 20,000 families worldwide in 45 different countries. So what do we do? The HCMA provides advocacy to those who are affected by HCM, education to all stakeholders, whether it be in the private or public sector, medical professional or patient. We work to educate everybody on what HCM is, isn't, and how to get appropriate care. We participate in scientific sessions. We share information with our research partners. We conduct some internal surveys of our organization in partnership with researchers and hope to expand our knowledge of HCM. We also work on clinical trial recruitment, and as well as helping the industries understand who we are, what we need, and how patients can get engaged with us to find support and education. So our missions are to provide support, education, and advocacy to patients, the medical community, and the public about HCM, while supporting research and fostering development of treatments. We strive to be the best organization we can be with a very limited budget, but we do try to provide a lot of services to the community, which we're going to talk about today. So for purposes of just understanding the scope of hypertrophic cardiomyopathy, for many years it was discussed as a disease that affects 1 in 500 individuals. And that was based on some old echo data that we looked at and found that even if we weren't looking for HCM, if you just looked at thousands upon thousands of echocardiograms, you would find that there would be 1 in 500 people showing up with hypertrophic cardiomyopathy. Excuse the COVID dog barking, but we're home. The prevalence of HCM has increased in our understanding to probably be closer to 1 in 200. And why is that change? Number one, we know that patients get MRIs now, and MRIs are more specific than echocardiograms. And we now know that there are genetic markers that can be identified to help identify families who are at risk for HCM. So we know that this is a familial disease, multiple family members can be affected. And this means that about 750,000 to 1 million individuals in the United States alone are affected by hypertrophic cardiomyopathy. Sadly, only about 120,000 of them are in care right now for HCM. So they're possibly misidentified, or they've just not figured out that they have a cardiac condition as of yet. We need to help raise awareness of this, and we have some initiatives that are going to help do that. So if you're watching this and you're at the Heart Failure Society Patient Day, you've probably been through a bit of a journey yourself to get to diagnosis of HCM. And maybe you're not even sure right now if HCM might actually be your diagnosis. We are commonly misdiagnosed with things like asthma, athletically induced asthma, specifically panic attacks, anxiety attacks, depression, mitral valve prolapse, and most commonly an innocent heart murmur. What are the symptoms of HCM? The heart murmur can be a symptom or a sign in and of itself. The symptom of shortness of breath, fainting or nearly fainting, lightheadedness or dizziness, chest pain or pressure, and for women that can go up the jaw and into the back of the neck, as well as chest pain, or it could be in the upper back. Patients with HCM experience a lot of palpitations and excessive fatigue. We know that sudden death can occur in hypertrophic cardiomyopathy. That's not exactly a symptom, it's more of a sign or an outcome. And if you have a family history of somebody who has had a sudden cardiac arrest, not a heart attack, a sudden cardiac arrest under the age of 55 or so, then, and you're having heart problems now, you want to think maybe this could be hypertrophic cardiomyopathy. So there are a number of different ways your heart can look with HCM, and that's part of our challenge. The hearts don't all look the same. They don't all do the same things. In this first image, you'll see that this is a normal heart wall. There's no excess sizes, more than 1.2 centimeters of the wall of the heart. When you start looking at without obstruction here, you can see that the walls are thickened down the center, and they can be very thick. They can be 2 to 3 times normal, meaning the septal measurement can be 2 centimeters or greater. Once we hit 3 centimeters or greater, that's a particular risk factor, but the walls can be misshapen and thickened in any region of the heart. So this would be a non-obstructed pathology here, where you can see that the blood that goes into the ventricle could leave through the outflow tract and aorta unimpeded. In obstructive hypertrophic cardiomyopathy, you'll see that there's this connection between the mitral valve and the septal wall, and the blood cannot appropriately leave the heart. So that's called obstructive HCM, or HOCM, some people call it. You can have this anatomy where the center of the heart kind of looks like an hourglass. It's called mid-cavity obstruction. And you can develop a pressure gradient in these hearts. And you also can develop problems in the apex, because you can have some ballooning in the apex of the heart. And then you can have an apical presentation where all the thickness is just at the base of the heart. So HCM doesn't look like one thing, it can look like many. And actually, as a consequence of long-term disease, the heart can actually turn into a dilated state and become weak and bulbous and look like a dilated cardiomyopathy, but it's the same genetic mutations that can cause both within the same family. So we're a little complicated. So what do we do about HCM? Well, most of us take medications, and 90% are on some type of medication. And there are some new investigational drugs being evaluated right now, and in the next couple of months might be available to the HCM community. But generally, we're using beta blockers, calcium channel blockers, a drug called disopyramide or Norpace, which is a unique formulation that works to help obstruction in HCM, and it also can deal with certain arrhythmias. There are other antiarrhythmic drugs that we would use, sotalol, amiodarone, et cetera, maybe Ticacin. We use diuretics, but not with severe obstruction. It's a complicated pathway there too. Anticoagulants, antibiotics, and I mentioned the investigational meds right now. About 20 to 25% of those with HCM will need to undergo a septal myectomy, which is a surgical procedure to remove the outflow tract obstruction, which can lead to symptoms and can also increase heart failure. There is a non-surgical option that is available for certain people with a very specific anatomy. This is called alcohol septal ablation, where they actually introduce a small amount of alcohol and burn the muscle through that release of alcohol. That can relieve obstruction as well. In rhythm management, we're dealing with pacemakers, ICDs, atrial fibrillation management. Less frequently, ventricular arrhythmia ablations are done, but more commonly in HCM, we do atrial arrhythmia ablations. Between 3 to 5% of us go to transplant. That happened to have been my pathway. I lived with HCM for 36 years myself, and almost 4 years ago, I turned in my old heart for a new one. Thank you, Brandy, because I went into severe heart failure. Only 3 to 5% of us go there. It's not the destination for most people with HCM. Okay. So there are different pathways in HCM management. Not every patient with HCM follows the same path. That is critical to understand, but you may find yourself going in multiple pathways simultaneously. Stick with me, I'll make it make sense. So you can be at high risk for sudden death, but you may not have any symptoms at all. But they've decided that your phenotype, maybe because of excessive scarring or family history, you don't need to have a symptom to be at high risk for sudden death. Now, you can be on that pathway and other pathways as well. You could be symptomatic, you can be asymptomatic. Progressive heart failure normally occurs with those with obstruction, and we would have to treat the obstruction. Advanced heart failure is when you're no longer obstructed and the heart is weakening or stiffening. So you can go two different ways. You can go like a dilated state, or you can go to a very rigid state. My heart turned into a little rock inside of my chest and was just really, really rigid, restrictive. So that's another pathway. And then there's those who have problems with atrial fibrillation and are at a higher risk for stroke. So there's therapies on each of these pathways. You may find yourself, maybe you're obstructed and at high risk for sudden death, and you need a myectomy and an ICD. Or maybe you're in end stage HCM, but you need the protection of an ICD because your heart is so unpredictable at this point. We know that those who have advanced disease need a defibrillator as well. Or maybe you're just an asymptomatic AFib patient, but you're still at risk for clots and strokes, so you need to be anticoagulated. So there's all these different pathways, and it's hard to figure out who fits into which one, and I'm going to get into that a little bit more in a second. There's also another group, the lucky group, the asymptomatic, low risk, gene positive. We just follow them. And things can change over time. You can be an asymptomatic 20-year-old and a mildly symptomatic 30-year-old and somebody heading for surgery in their 40s. Or it could go on a completely different timeline for you. So it's really important that patients with HCM stay in touch with a high volume center of excellence to get their care, which I'll talk about in just a moment. So the average cardiologist in the United States sees about 2,000 patients. That means within a practice of a general cardiologist in the community, maybe they see 10 people with HCM, maybe. Now, what are the chances that out of the 10 patients a regional doctor or community-based doctor has, that they're going to really be experienced in each one of these different pathways for a disease that affects a small minority of their patient population? Probably not going to happen. So we'll talk a little bit more about that later. Just put some statistics on here so you see who falls into which I kind of talked about earlier. So our Center of Excellence program, so the Hypertrophic Cardiomyopathy Association came up with a set of standards that we as the patient community know we need in terms of our care team at an HCM center. So we developed a program called HCMA Recognized Centers of Excellence, which now has approximately, 41 programs with 8 under review at this time. There's a full directory of all of our high volume centers at 4hcm.org. Each center is a little bit different. They vary in their experience level, in the services that they provide, but generally speaking, they all have a similar model. Some don't go to the point where they include a transplant program, or maybe they don't have maternal fetal health, or maybe the PEDS program is in an adjoining hospital. So they're all just a little bit different based on the region of the country that they are serving. So we have a little fun with our graphics here, so bear with me. An HCM Center of Excellence is run by a person we lovingly call a Hokamologist. Basically, it's a physician who runs the HCM program. Typically, they come from the world of imaging, so they're echocardiographer types and cardiac MRI related physicians. So they have experience in real high volume imaging. So there's different levels of imagers. These are the highest level imagers in cardiology. Or they come from heart failure. So they work in a heart failure program and they're a traditional heart failure doc who happens to have taken a liking for this unique disease, and they take it on as a separate kind of practice within a practice. And there's a few other subspecialties that do run some programs. We have a couple of interventional cardiologists and a couple of electrophysiologists who run programs, but primarily it's the imagers and the heart failure docs that run the program. And they kind of take control. If you were to think of kind of like the old days of an HMO having a gatekeeper doctor, this is your gatekeeper HCM cardiologist. So all of these lovely people up here holding their hearts and waving at you are representative of us, the patient community. The Hokamologist puts them through a pathway which looks at imaging and EP and heart failure, genetics and mental health services. And maybe you have to go filter out and you need to go to EP for a while because you're going to get an AFib ablation. Or maybe you need to go see the geneticist to see if you can find the gene in your family. Or maybe you need an interventional cardiologist to check your pressures in your heart, so they'll do your caths. Or maybe you need open heart surgery and you'll head to the surgeon. But then you head, oops, my graphic didn't quite work there. Sorry about that. You go back and you go back to your Hokamologist. And the reason that this is critically important is patients with HCM who can go in different pathways. Sometimes if you're viewed as high risk of sudden death and you land your treatment with an electrophysiologist, they're thinking EP, they're thinking rhythm. Meanwhile, the heart is getting weak or stiff, or there's something wrong with the outflow tract. That's where you're going to get your Hokamologist more involved in understanding what else is going on with your heart. So it's critically important that we move on to a program that has that gatekeeper HCM care doctor at the helm. So there's a new document out. It's called the American Heart Association, American College of Cardiology Guidelines for the Treatment of Hypertrophic Cardiomyopathy. And they have embraced our Center of Excellence model. And they went and defined it a little bit differently. So high volume center of excellence based on our criteria. While they didn't say that in the document, that's what they did. So we thank them for that. These are where you can get the highest level of diagnostics, invasive therapies, surgeries, transplant, everything can be done under that roof. Some of our other programs are what you might call a primary center. They don't have a surgeon there. They refer to somebody else for their surgeries. They don't do transplant. They might not have maternal fetal health under the same roof. So they'll have relationships that they've established that will get you the care that you need. And then the role of your primary cardiologist is still critically important. You need somebody in your hometown who knows you and is communicating with your HCM team that might be, across state or maybe in another state. So you need that team approach, because if you had a crisis at home, you want somebody there to know who you are and what's going on and give them the resources to help you best, because you've established care with a high volume center of excellence. So what do we know about the patient perspective about these centers? Based on surveys, we know that patients find these programs way better than the treatment that they've received at the community. They feel understood. They feel that the quality of their physical life and emotional life have been improved because they're getting treatments that are more consistent with their disease process by people who understand the nuances of hypertrophic cardiomyopathy. We know that the outcomes from invasive procedures have lower complication rates when we compare centers of excellence to community care, and the patients benefit from that. They don't have as many readmissions to the hospital after surgery. They have appropriate therapies when needed, and they're saved from not having procedures and tests done that aren't really going to help the outcomes change at all. We know that they have the ability to participate in clinical trials, and there's a lot of exciting clinical trials going on today in HCM, and you can go to our website to learn more about them. We know that, as I mentioned, the high volume center experience for surgery is striking. When there was a meta-analysis done and they compared community cardiology practices or surgical practices to center of excellence, 1 in 8 patients having a myectomy in a small low volume center did not fare well at all. In fact, many of them died. When you compare that to a center of excellence, 99.7% or 6% survived the surgery and 30 days thereafter. So the outcomes are so much better when you have people who are specialized in it. We know that the patients are going to get the right level of care, not overtreated, not undertreated, but finding that balance, which is critical. And we know that they're less likely to receive therapies that are inappropriate or in fact contraindicated. There's a lot of medications that can actually aggravate the HCM heart that doctors who don't know a lot about HCM tend to put patients on. So we can avoid that problem. So I'm going to pivot for a moment and discuss some of our social media presence, because if you're watching this and you're a patient with HCM and you'd like to get involved, here's where you can do it. So our HCM Facebook page is this top page here. That's the anchoring page. And then we have several groups associated, and we're building out more groups for different countries coming up in 2021. So you can join us on Facebook. Please like our page. We're ready to hit a milestone number. So go in there and like us, and we'll hit our milestone number and we can celebrate. We are working on our online support group systems. We are actually starting them. We've been planning these all fall. Our first one will launch on December 8th. That's a pre-myectomy call, and the people participating in that group will all be scheduled for surgery in the next 30 or so days, and they'll be getting ready for their surgery. There are going to be 20 different groups available each month. with different hosts and different personalities running these programs. And we're really excited to get y'all involved in these groups to better understand all aspects of HCM. Some of these programs will be very educational. Some of them will be more support and Q&A related. And we're going to help develop this system out together. So please share your feedback and comments with us as we progress. We're also doing a Share Your Story program. So if you have hypertrophic cardiomyopathy and you would like to help educate others, please reach out to us and we can help you share your story. At this time, we're putting a special call out to communities of color. We need to hear from our HCM big-hearted brothers and sisters from communities of color, specifically the Latino and African American community. We have to show the true face of hypertrophic cardiomyopathy, and we are all races, all different ethnicities, and any gender, any age. So if you're a family with HCM and you want to share your story, you can do that as well. So contact us at 4hcm.org. Our email is support@4hcm.org. You can find that in the directory for the HSFA meeting, and hopefully we'll hear from you. You can also tune into our podcast, available wherever you get your podcasts, called Tales from the Heart. And I have conversations with patients and physicians and thought leaders and industry representatives and authors, and we talk all things about the heart, mostly about hypertrophic cardiomyopathy, but sometimes we go into other tangents. We are going to be kicking off our legislative efforts for the hopeful inclusion of cardiac screening in all well child examinations. Believe it or not, only the state of New Jersey currently asks questions in a well child exam about heart history, and we need to change that. And this is an easy one. It's a bipartisan effort. Hold on one second. I'm just going to put that on Do Not Disturb. There, I put it on Do Not Disturb. Sorry about that. It didn't work. I will get back to them later. So I just want to finish this video. And sorry, I'm going to call them back. So the legislative subcommittee will kick off our work. We have identified a number of states that we're going to start targeting and hope to move this state level legislation forward so that we can help ensure families with hypertrophic cardiomyopathy and other genetic and acquired cardiac disorders get the opportunity for timely diagnosis and treatment. There's other issues we'll get involved with, but this video is running a bit long. So I want to say thank you very much to HSFA or HFSA for asking us to be a partner in their Heart Failure Education Day. All of our Center of Excellence partners, we couldn't do this without you, and we thank you very much. And of course, to my donor family and my heart donor, Brandy, I wouldn't be here without you. Thank you so much for your time and attention today, and please visit the HCMA for more information.